Okay, we're going to get started, so thanks everyone for being on time, and welcome to Friday, October 25th. Great pleasure to introduce Manish Sood. He's the Associate Professor of Medicine at University of Ottawa and also the Jindal Research Chair for Prevention of Kidney Disease. He did his training in Toronto and subsequently started his career at the University of Manitoba in Winnipeg and has since gone to the University of Ottawa. He is the reason that the Canadian Journal of Kidney Health and Disease exists. He was the true brainchild behind that, is now the Deputy Editor-in-Chief, and has written many papers and done a lot of great work with core as well as other data sets. And so we're looking forward to his conversation today and hopefully some time for discussion. So welcome, Manish.
Thank you, Adira. And is that okay for Mike? Yeah. Okay. Thanks for the kind words. I'm happy to be here. I had a great time in my visit so far to Vancouver, and you guys are terrific hosts, so thanks for having me. Today I'm going to talk about anticoagulation, and I'm going to focus a little bit on what I'm hoping is new information for most of the listeners. What I'm going to focus on is the newer anticoagulants, which we call the direct oral anticoagulants. And the idea here is many of you think, well, we use these anticoagulants in the setting of venous thromboembolism or atrial fibrillation. I'm going to come at you with a new concept with the idea of using anticoagulation to prevent cardiac disease in patients with chronic kidney disease. As you can see, some of my credentialing and whatnot is all here, doesn't matter. The more important thing is right here, my Twitter handle. So please feel free. I know these are formal settings. It's not easy to give feedback or ask questions. So feel free to tweet me anything you want. You know, your talk is terrible, your personal hygiene is questionable, whatever. It doesn't matter. It's open forum, so go for it and feel free to tweet. So as Dr. Levin mentioned, one of my activities is as an editor and as a researcher. And so I always find it a lot of fun to have quirky stories related to journals and publishing and academia. And I want to share with you one of my favorites. So this is, and I didn't put a black bar de-identifying anything here. I'm shaming the journal that did this, the International Journal of Stroke it's called. And if you read through this, it's a review invitation sent to me for this journal as a peer reviewer to review this paper. Dear Dr. Sood, manuscript number, the risk of stroke and stroke type and risk in patients with atrial fibrillation and chronic kidney disease with Dr. Sood as contact author has been submitted to the International Journal of Stroke as a research article. My favorite example of journal misadventures, this is my own paper that I wrote, and they're asking me to review it. So I always like to share. This is the first time this has ever happened to me. I liked it very much. Nevertheless, I reviewed it and trashed it. It was junk. But that's an aside. I just thought this was a 1 in a million. My disclosure's up front, so I take money from anybody who will give it to me, but no one gives me it. Otsuka, I did some grants work for them. It was all investigator-driven, nothing related to the content today, and I've spoken some content for AstraZeneca as well, nothing related to content today. So the outline of today's talk is to review the role of anticoagulation in the prevention of cardiovascular disease. So this is going to be a cardiology-heavy talk, and in that regard, I'm hoping I'm presenting new information to a nephrology audience. I'm going to review the evidence for DOAC use and cardiovascular outcomes, and then I'm going to pitch to you the idea of a trial called the TRACK trial that's coming down the pipeline, and I'm hoping that BC will partner with us and be heavily involved in this upcoming randomized controlled trial. So let's start with some cardiology history. So anticoagulation to prevent cardiovascular disease is not new. There were a lot of trials in the late 80s and 90s for using mostly warfarin to prevent a recurrent acute coronary event in people who've previously had one. So the idea was you give aspirin to inhibit the platelet pathway, you give warfarin to inhibit the secondary hemostasis pathway. In general, a lot of these trials were done in people, as I mentioned, to prevent the outcome of ACS. They were short-term, 1 to 3 years. They were aspirin versus aspirin plus warfarin. And they had variable INR targets. So they looked at targets from 1.5 up to 3.5. This is a systematic review of all those trials. First thing I'd like to impress on you is there were a large number of patients in these cardiology studies, 14 trials, 25,000 patients randomized to a warfarin versus antiplatelet strategy. What we have here is the line where there's no difference between the two, whether they favor aspirin or warfarin versus favors aspirin, not statistically significant. In other words, the addition of warfarin made no difference. However, the addition of warfarin tremendously increased the bleeding risk. So in this, it's favoring as in positive benefit, so there was much less risk of bleeding with aspirin or much more with aspirin plus warfarin. Is any of that surprising? Not at all. Thanks, Dr. Sood, for your boring presentation. And as you can see, the guidelines in cardiology completely understood this and said they recommend aspirin over warfarin alone or in combination to prevent ACS. Nothing surprising there. Very boring information. We all know this. We don't see people on warfarin to prevent ACS. But it's not that simple. The story is much more interesting than that. When the meta-analysis restricted the trials to patients with INRs between 2 to 3, what they showed, a large number of patients, almost 8,000 randomized, is there is a benefit to aspirin plus warfarin in reducing cardiovascular events. And it was statistically significant by quite a bit, 27% relative risk reduction. The hemorrhage risk was still there with the two. So that led to some modification in the cardiology world of what's the relationship of using warfarin to prevent cardiovascular events. And they said in select patients, maybe if we monitor the INR very, very closely, this strategy is possible. And it was a grade 2B recommendation about a decade ago. But Dr. Sood, why don't we see people on warfarin plus platelets to prevent heart attacks? Because right at that time, dual antiplatelet therapy emerged as the front runner. So I know this is a nephrology audience, but in cardiology, a lot of people who have an ACS will receive a combination of ASA plus or minus clopidogrel or Agrinox or some other antiplatelet agent. So you get two antiplatelet agents. And a large number of trials came out showing this strategy was safe and effective, and it essentially took over cardiology. So this whole idea of using warfarin plus aspirin just fell to the wayside because the bleeding risks with dual antiplatelet therapy were much lower. This idea of warfarin was relegated to very specific scenarios. And you may have seen some of these, ACS with a left ventricular mural thrombosis, anterior apical kinesis, somebody who's on dual antiplatelet therapy who's having recurrent ACS. But these are grade level C evidence. So this is terrible evidence where essentially it's people meeting in a room and coming up with a consensus opinion. But one interesting thing was the introduction in the late 2000s of these newer types of oral anticoagulants. And what I mean by these, primarily in Canada, it's apixaban, dabigatran, and rivaroxaban. And these new agents, which are generally easier to take, slightly more efficacious than warfarin, and less side effects, meaning hemorrhage, has renewed interest or recycled this old idea of giving an anticoagulant to prevent cardiac disease. How about a sidebar on DOACs and their use in Canada? So this is the only study that I was able to come across showing what DOACs are essentially doing in the marketplace. So they were first introduced in 2007, but they went through CDR, Canadian Drug Review approvals, a little later on. As they've been approved, first dabigatran, followed by rivaroxaban and apixaban, they've gradually increased market share, taking away from warfarin. This isn't surprising. These drugs are really, from a patient perspective, they're really nice. You don't need INR checks. They don't have as many drug interactions. They're very easy to take. If you extrapolate this even further, and I don't have the data Canada-wide, but at least in Ontario, what you see is actually after 2014, an exponential decline in warfarin use and a massive increase in these drugs, with rivaroxaban being the clear market leader. We've had a trickle-down effect to our world, meaning nephrology patients, with these drugs. This is American data looking at CKD patients, and what they've seen there is, in the beginning, yes, dabigatran, which is renally excreted, which causes some problems, started having market share, but then rivaroxaban and apixaban started to take off, and they're started to be used more and more commonly, despite having direct evidence of safety and efficacy in our patient populations. These have even found their way into the dialysis population, where apixaban has essentially become the alternative now for warfarin. Again, the only safety data we have is pharmacokinetic data. We don't really have any really patient-based data except this kind of observational stuff. But it's coming, and I anticipate in the next decade or so, it's going to take over as we see a number of trials coming down the pathway. Why is any of this a concern? Why is CKD a big deal? Why are we distinguishing effects in CKD versus non-CKD? The problem is, as your GFR declines, your risk of having a major bleeding event goes through the roof. This was some data that we published a few years ago now, and what we have here is the cumulative incidence in percent along the y-axis and eGFR groups along the x-axis, greater than 90, 60 to 90, 45 to 60, all the way down to less than 15. And if you look, the blue bar is the relative risk, unadjusted, of a hemorrhage requiring presentation to the emergency room or hospitalization. And there's a stepwise increase as your GFR declines, such that when you're end-stage kidney disease, the risk is 17 to 18-fold higher than if your kidney function was normal. When you look at the type of hemorrhage, the most common types were lower GI bleeds followed by upper GI bleeds, which you can imagine are rarely fatal, but could be traumatic and cause anxiety. And they also require hospitalization plus invasive intervention often for management. The much more fearful ones are less common but prevalent of subarachnoid hemorrhage and intracranial hemorrhages, which again also increase with lower eGFR. An idea of a way to look at this risk is to compare the healthiest group that we studied to maybe the most sick group and look at the risk difference between them. So if we compared in our study 45 to 65-year-olds who had no previous risk of a hemorrhage event with normal kidney function to people who were greater than 66 who had a previous bleeding event within 5 years, who were ESRD or CKD stage 5, the risk increased 44 times. So just to give you an idea of how prevalent and significant bleeding is in our population. And I think this causes us anxiety about prescribing anticoagulants and antiplatelets willy-nilly in this group. So that being said, let me come back to the cardiology stuff I was discussing. I left off where I was proposing that the introduction of DOACs has changed the thought process behind can they be used to prevent cardiac disease. This is a summary of major cardiac trials looking at these interventions. On the top, I have 4 phase 2 trials, which are often drug dosing discovery trials. And on the bottom, I have a couple of phase 3 trials. What I'd like to impress on you is a few things. Look at that cohort sizes. These are huge randomized trials. I wish, and I think everybody who's in nephrology wishes we could conduct such large trials regularly with such big numbers. Unfortunately, nephrology is the lowest number of randomized controlled trials. The second thing is the varied dosing that's being examined in these drugs. And what they were being given for was a reminder to prevent a cardiac event or major adverse cardiac events. So what they saw, the results were the hazard ratio for example, dabigatran for reducing cardiac events compared to placebo, it was numerically lower. And what I meant by that is it's not statistically significant, but the people who got the intervention had a lower number of events or proportion compared to those that did. But the bleeding risk was significantly increased. The ATLAS trial, which looked at rivaroxaban, various doses, had a significantly reduced risk of MACE, major adverse cardiac events, and probably a signal towards increased bleed, but not enough events. Another one of them, looking at apixaban, showed, again, a smaller number of events in the treatment arm, but it was terminated early because of the increased bleeding risk. Anyway, a few of these were further pursued in phase 3 trials, apixaban and rivaroxaban. And I'm going to point out some details which I really want you to appreciate as we go forward. Full dose of anticoagulation, the full dose for rivaroxaban is 15 to 20 milligrams a day, okay? They looked at doses as small as 5 milligrams a day, 2.5 BID, or 10 milligrams a day. So these are sub-therapeutic anticoagulation doses that they're looking at. What they found in their initial studies with apixaban, there was no improvement in the reduction of MACE, and the study was terminated because there was increased risk of bleeding. Rivaroxaban showed a clear signal for improvement, and the reduction was primarily driven by decreases in death. Both of them were statistically significant, both doses, with an increased risk of bleeding events. That was very interesting. And that led to one of the largest trials that maybe some of you have come across in this area, the COMPASS trial, which was published in the New England Journal in late 2017. The PI is Dr. Eckelboom from McMaster University. So it's a homegrown Canadian PI trial, which is terrific. This was an international study looking at almost 28,000 patients, and it randomized them to 3 arms. Low-dose rivaroxaban, 2.5 BID, high dose plus aspirin, so low dose plus aspirin, high dose 5 BID, or aspirin alone. And the inclusion criteria were people who had a history of vascular disease and were over the age of 65, or vascular disease under the age of 65 and risk factors. And this is why I've been going through all of this, telling the nephrology audience about the cardiology, because the risk factors were smoking, diabetes, EGFR under 60, CHF, previous lacunar stroke. Why is this important? Because the bulk of cardiology trials exclude people with CKD. This one actually enriched it. They actually went out to recruit people with CKD. This is going to turn out to be one of the largest, when I show you it all, it's one of the largest cardiac trials in a CKD population. So what did this trial show? This is the cumulative risk of cardiovascular death, stroke, or myocardial infarction. It was worse for aspirin alone. It was slightly improved to aspirin with rivaroxaban alone, and it was the best for rivaroxaban plus aspirin. It was statistically significant with a hazard ratio of 0.76. They terminated the trial because they showed that this was effective at this point. Now you ask, what is the bleeding risk? Well, the bleeding risk was increased. The low-dose rivaroxaban plus aspirin versus aspirin alone had a 1.7 hazard ratio of bleeding. High dose versus aspirin alone had a 1.5. So there was no real difference between the low versus high dose. Getting a rivaroxaban increased your risk of bleeding, but it reduced your risk of having a major cardiac event. These results are so compelling that this low-dose indication for rivaroxaban has been approved for use in Canada, Europe, US, and Australia. And I don't know if nephrology audiences are really aware of this. This only happened in 2018 in Canada. So these things are here and they're being used for these purposes. As I mentioned, this was one of the largest cardiac RCTs in CKD. If you look at the numbers, so what I have here is the group of people with EGFRs less than 60 versus greater than 60. There were 2,000 people randomized to each arm with GFRs less than 60. And a nice number of events to have a significant outcome were on both sides. And you can see clearly a 2% absolute reduction in your risk of having a MACE, major adverse cardiac event, with the addition of rivaroxaban. This was statistically significant and no different than the results with people with GFRs greater than 60. They just published the renal sub-study of COMPASS. And I'll be honest, this is a whole bunch of numbers. It's more we're looking at it for an interest, but the numbers are all too small to do too much takeaway messages. But I just wanted to show you it for completeness. What they showed was all the outcomes and harms by GFR groups less than 30, 30 to 60, greater than 60. You can see there were relatively few people, in a total of, 150, 60 patients randomized with GFRs less than 30. A fair number in the 30 to 60 group, the bulk, were in that group. And what you kind of see, even though the numbers are very small, is similarity, a similar efficacy signal with lower levels of GFR. I don't think that's that surprising, but this was just recently published, again, small numbers. And again, through the major bleeding, it does show, again, very small numbers, maybe a slightly increased risk of higher bleeding with the rivaroxaban plus aspirin group, but again, the numbers are so small, I wouldn't even draw any conclusions with this. One thing I thought was interesting, though, is this concept of net clinical benefit. The idea of net clinical benefit is essentially tallying up how many good things does this drug do for you, prevent heart attacks, prevent death, prevent stroke, minus how many bad things this prevents for you, bleeding. And you could argue that really is one bleeding event equal to preventing one heart attack. That's a personal judgment. But a lot of times when they do net clinical benefit calculations, they just treat them as one-to-one. They don't put a judgment on them and just say this bad event is equal to a good event, and they analyzed it this way. So when you look at the net clinical benefit by GFR, it is clear for people with a GFR greater than 60. It touches the line of significance, but is still significant in the 30 to 60 group, and probably there were too few events in the less than 30 group to give us an answer. And this is the people we want to know, because these are the people who have such a high bleeding risk that these are the people who are really concerned, is there a net clinical benefit in them? Again, just looking at the numbers, because sometimes it's not clear how impactful these findings may or may not be. The absolute, I'm back. The absolute risk increase in major bleeding for people who had an eGFR less than 60 was 1.3%. For those greater than 60, it was 1.2%, identical. The absolute risk reduction in MACE was 2% with those in GFR less than 60, 1% in those greater. So maybe there's more benefit. Maybe. What do these results mean in context? So these are other famous cardiac therapies that are widely used. Aspirin to reduce a cardiac event in people with high risk in the general population is a 19% relative risk reduction. Dual antiplatelet therapy, 7 to 16%, depending on the study. Warfarin, 19 to 29%. Rivaroxaban, 2.5 milligrams in the general population to reduce a cardiac event, 24% relative risk reduction. In the CKD subgroup, it's 25%. To give you context of how this intervention compares to other cardiac interventions. So this is powerful stuff, and it deserves further exploration. And now I'm going to shift, after kind of focusing on a lot of cardiology, I'm going to shift to how can we go forward with this in the CKD world, and what is some potential data that has come out of the CKD world in this area. So I'm going to try to fill some knowledge gaps and discuss some of the work we've been doing in this area. The first thing I'm going to talk about is the idea of, can you see a signal of this cardiovascular benefit in CKD patients comparing DOACs to warfarin? Now, why am I doing that? Well, because we don't have the studies in this patient group, but maybe if we look at just DOACs versus warfarin, we might see a similar signal of benefit to reducing cardiovascular risk. The second thing I'm going to discuss is a CKD-specific trial in this area. And the third thing is this whole idea of net clinical benefit. Are there any patient tools to help them decide risk versus benefit with using anticoagulation such as this? So let's go through these three areas. The research question, we call this, I consider this a low-hanging fruit because we have the retrospective databases to look at a quick question like this. It might give us a bit of a signal to further strengthen the COMPASS trial. So we looked at DOACs, but we compared them to warfarin users, and we looked if they reduced cardiovascular events or increased bleeding events in anticoagulated patients by CKD stage. This work is currently in revision, so it's a bit in flux, but hopefully you'll see it in publication early next year. We did this work in the Institute for Clinical Evaluative Sciences, which is lovingly called ISIS. So an aside on our name, because a terrorist group swiped it and it suddenly had a bad connotation. We had this name before, the other ISIS. Because of that, they went through a rebranding and renaming exercise because they wanted to get away from that. So it was like a $60,000 thing, took 2 years, multiple panels, committees, bureaucracy, all this stuff. And at the end of it, they came back and said, we'll name it IC/ES. So your tax dollars at work, that was the rebranding and renaming exercise. So now we call this ICES as our rebrand. So what it is an administrative database that's in Ontario, and what they've done is linked a whole bunch of useful data sets together. They have all hospital services, hospitalizations, healthcare claims, vital statistics, and now we have labs for everybody from 2007, so we can define kidney function. And we have medications for everybody over the age of 65. A lot of people, look at administrative data and say, that's dirty data, it's retrospective, what do you know, what are you really sure what's coming out of it? There's a lot of advanced administrative data science that's been taking place. And I want to at least impart on you that there's ways to distinguish good data science from bad data science. And one of them is the use of validated definitions. So for example, you define things using codes in the administrative data. Many codes have been validated where they go and pull charts and look how commonly the disease that's in the database matches the codes. There have been systematic reviews of validated definitions where you can get sensitivities and specificities over 90%. And so when you read these studies, you want to see that people are using validated definitions that are very accurate. And this is one of the things we try to embed in our work. And it's a good way to see good from less good data science. That being said, this was the study design. So we looked at all patients who were greater than the age of 66 who had 2 serum creatinine values 3 to 12 months prior and an ACR prior to a new anticoagulation prescription. Why did we use 2? Because creatinines fluctuate. And we wanted to make sure these people had a somewhat stable baseline serum creatinine because we're interested in stability, not in AKI. We then looked at them and whether the effects differed by eGFR groups, greater than 90, 60 to 89, 31 to 60, less than 30. We found 47,000 patients who were receiving new anticoagulant prescriptions. 39% of them were on DOACs, the bulk were on rivaroxaban. Our study outcome was coronary artery disease as measured by a whole bunch of stuff, ACS, CABG, PCI, stroke, death, and then we looked at all of these kind of components individually and hemorrhage. We did some fancy smancy stuff called a high dimensional propensity score match for these patients, and you're going to say, what? Who cares? I'll explain in the next few slides what that is and why it's interesting. I am at heart a data geek, so I apologize, but if I love this, I'm taking you with me. So what is propensity score matching? If you've read this, what does it mean? What does it imply? Well, when you do these data studies, there's no randomization, right? It's retrospective. So the patients who get the drug are completely different, in this case, warfarin from DOACs. And I'm using an example from a previous study here to illustrate where we looked at SPS. And we looked at like 1.8 million people, 27,000 got SPS, controls were 1.8. And when you look, they're fundamentally different people. The age was different by about 4 years, SPS was older. There was a different proportion by sex between the two groups, and this list went down for every variable we use. So what the propensity score does is it's a mathematical way to focus and eliminate people who are different and look at people that are similar and compare them head to head. And in that sense, it mimics a randomized control trial. You know, in a randomized control trial, you look at your table 1 and everybody's balanced. That's the principle of randomization. The idea here is, can we mathematically mimic a randomized control trial? So after you do your matching process, yes, you lose some of the original patients who couldn't match, but you get a balanced cohort. There's no longer any differences between the two groups. So the age is same, the proportion by gender is same, and you can look for, you know, whatever number, 100 variables there for matching. Then it's like you're theoretically conducting a randomized trial, comparing apples to apples versus apples to oranges. So what is a high dimensional propensity score? Whoa, let's take it up a notch. Okay. So how do we decide what to include in our propensity score match? Well, they turn to me, the analysts or even myself, and say, Dr. Sood, use your clinical expertise to tell me what we should include in this model. And I say, well, blah, 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 because I know everything, right? Or any of us know everything. We know all the factors that are involved to match on to make the two groups the same. The reality is we don't. And it's counterintuitive, but we don't know what are some of the things that are very highly predictive for patients. And I'm going to give you an example. One of the highest predictive risks of dying within a hospital, it's if you have diabetes, if your age, you know what one of the highest risks are? The frequency of lab tests you have. None of you would think of that. I wouldn't think of that. It's completely counterintuitive. But that was published in the BMJ. And it was a well-done study. And the reality is we have to accept what we don't know and try to use those to better our results. So that's what the high dimensional propensity score does. Instead of a traditional modeling system where you choose, I'm going to do diabetes, and then it's entered as diabetes yes, diabetes no. That's it. Think about how much information is lost there. Your diabetic patient can be an 86-year-old who's diet controlled with a hemoglobin A1C of 7 on one measure, or it could be someone who has no limbs, orthostatic hypotension, is blind, and is on an insulin pump. They're both one in the way this is looked at. But we know that's not one. There are huge differences in those two groups. The high dimensional propensity score attempts to account for that. And the way it does it is it looks at many variables to try to account for illness severity. So instead of just looking at diabetes yes, no, it will look at how many hospitalizations did they have with the code diabetes in it. How many physicians did they see who were coded for diabetes care? How many times did they have procedures related to diabetes ulcers? How many medications are they on related to diabetes? And it gives you much more detail and richness on the severity of these conditions. The second thing the high dimensional propensity score does is it doesn't depend on me to pick what's important. It's a computer algorithm. It does it itself. It automatically looks at all the variables and ranks them by how closely they're associated with your outcome, and then multiplies them by how frequently they occur. So it's very objective, it's very mathematical, and because of that, I personally like this methodology. I've been using it a lot. It's something you can only use in administrative databases, but in the end, instead of matching on 30 variables that you choose, you can match on 300 variables. Numbers will allow for it, and it's numbers that have, and it's the data algorithm searching out these things and making the match better. This is the theory behind it. So here's our excellent IC/ES $60,000 rebranding name. And so this was the outcome of our study. So we ended up matching 8,000 patients, average age 77, 44% were women, 60% were diabetic. We identified a clear indication for anticoagulation in only 60% of them. 24% with AFib, 35% with VTE, and a fifth were on antiplatelet agent. And what we saw was that those who received DOACs had less primary events, which was death or cardiovascular, compared to those who received warfarin. When we did it by cardiovascular alone, it was favoring it, but it wasn't statistically significant. When we looked at hemorrhage, it was favoring it, but again, no statistical difference between the two. But that wasn't the question of interest. The question of interest is what happens in CKD, and that's what this is. So I'm going to walk you through this. On the x-axis is the hazard ratio. On the y-axis are outcomes by eGFR group, so cardiovascular event or mortality, cardiac events or hemorrhage. And what I would like you to appreciate is this pattern. What you see is a stepwise reduction in the risk of cardiovascular events or mortality with declining eGFR among DOAC users compared to warfarin. It was statistically significant for both cardiovascular plus mortality and cardiac events. And you can see the pattern. It's quite nice. There seems to be a reasonable number of events. Hemorrhage appeared to be no different between the two. But hemorrhage isn't everything. We also looked at serious hemorrhages, intracranial, and DOACs there had a numerically lower risk, but again, it was small. So how do we interpret these results? One way you can interpret it is DOACs are good. They're reducing your risk of cardiac events. But you can also interpret it as warfarin might be bad. And why is that? Is that even feasible? Well, warfarin is a vitamin K antagonist. And there's been a lot of emergence of recent literature showing that it increases vascular calcification, and it's one of the biggest risk factors for calciphylaxis. So it could go either way. This could be that these patients' warfarin is slowly calcifying them, putting them at higher cardiac risk. Or it could be DOACs are beneficial, and we're seeing kind of the same signal that was seen in the cardiology trials. It does raise the intriguing possibility of should patients with an indication for anticoagulation who are currently on warfarin, should they all systematically be switched to a DOAC? I don't think any of this evidence is conclusive, but I think it's a start down the path of maybe they should. And can DOACs be used as a preventative therapy for cardiovascular disease and CKD? Again, suggestive, but this is not definitive. We need an RCT. Good thing we have one coming. So the TRACK trial is an upcoming study, which is the treatment of cardiovascular disease with low-dose rivaroxaban in patients specifically with advanced CKD. The trial design is an international multi-center placebo-controlled trial where we're going to recruit and focus on CKD stage 4, 5, and dialysis. This is us. This is our trial that we kind of, in many ways, waiting to see it's happening. They have to have a risk factor of coronary artery disease, peripheral artery disease, a previous stroke, age greater than 65, or diabetes. A pretty inclusive inclusion, I think. That's a lot of our population. And they're going to be randomized to low-dose rivaroxaban 2.5 BID versus placebo. Everybody who's on aspirin can be continued. It'll be stratified by aspirin. And the outcome will be a composite of cardiovascular death, ACS, stroke, and the trial will be endpoint driven. So it will end when enough endpoints have been reached, which I think is roughly like 800 or something. I don't remember offhand. The status of this trial is it's funded. In Australia, the PI, Sunil Badvi, has got over $5 million to start this work. And so they've started recruiting, and they're starting in Asia and Australia. We have submitted a CHR grant with PIs here, Mike Walsh, John Eckelboom, who was the PI on the COMPASS trial from McMaster, and myself. We went through the first round. We didn't get it, but we've revised and resubmitted, so it's there now. So fingers crossed, and hopefully we'll be able to do this trial and bring it to Canada. And in that regard, hey, we want you. We want Vancouver to be a key part of this. You know, not Vancouver, BC, excuse me. BC has been a terrific research partner and is very trial progressive. And so we're hoping that you'll be involved with us if this trial gets funded in this research endeavor. And I want to use American wartime propaganda to try to convince you to join. I think my last slide is coming, and then we'll have nice time for questions or discussion. All of this is very interesting, good for you, terrific work, fascinating stuff, but the landscape has changed. The landscape has changed from us just doing trials for outcomes that are relevant to us, meaning healthcare workers, to reaching out, extending a hand to our patients and asking them, what do you want to learn about? What do you want to do? What matters to you? How do we help you individualize your decision making? And I think with any of these things coming forward, it's not simple enough for us to just say, hey, this drug will reduce your heart attack risk, take it. I think if you talk to people, a lot of people have different beliefs, fears, risks, and they want to make individual decisions. And part of the difficulty in making individual decisions is we often don't have enough time to explain things adequately to them. So we designed an app that I call a mini decision aid, and we call it DecisionMD. And the idea is this app is based on something called risk-benefit trade-off methodology. And what it does is you'll go into this app, and first iteration is on anticoagulation, and for AFib. So it will explain, you have a heart arrhythmia called atrial fibrillation, it puts you at increased risk of stroke, your risk is X. Then it'll explain what happens if you have a stroke, then it'll explain the complication of major bleed, and then what it will do will give you pictures illustrating benefit and risk in picture form, in words, and it'll ask you, knowing these risks, would you be willing to take an anticoagulant? And say the patient says, yes. I'm willing to take an anticoagulant if it reduces my stroke risk from 6 to 4% per year, and my bleeding risk is 6. And then the next part will go, okay, what if it only reduced it from 6 to 5 and your bleeding risk went to 10%? And then they'll say, no, I'll still take it. Then it'll go, what if the bleeding risk was 20%? And it does this exercise to focus in exactly on how many adverse events they'd be willing to accept to have a benefit. And it gives you, at the end, a simple math illustration or a ratio of these things with explanation that perhaps you should consider anticoagulation therapy or not, talk to your physician. This idea can be used for any risk-benefit scenario. You're going to assign a statin to a person who's an active exerciser because they have hyperlipidemia. They're worried about the myopathy risk. You go through this risk scenario, exercise with them, you let them fill it out themselves, and it shows them their benefit and risk. Where do we get these numbers that fill it? From the ICIS data or from randomized control trials or meta-analyses. So we try to use the best data and vary around those numbers to try to illustrate the risk and benefit and let patients make individual decisions. The other place this would work well is surgical procedures, which always have complication risks. So we're using this and actually undertaking a study with this now in the CanSolve III network looking at anticoagulation, but this could directly be used with the question of DOACs and preventing cardiac disease as well. And the way we design the app is that it's easily reprogrammable by individual researchers. We wrote a little leaflet on how to do it. And so if anybody's ever interested, we're willing to share this, of course, with researchers for free. For pharma and policymakers, we charge massive bucks. But for you guys, we'll give it to you for free if you're interested in research in this area. So how do we pull this all together? We've got a good block of time left. So DOACs are rapidly capturing market share. I hope I've kind of showed you or illustrated this. If you're not seeing it yet, you're going to, because these are coming, and they're going to come down the pipeline. If they're being prescribed in people with normal GFRs, those people are going to progress with their CKD, and you're going to start seeing them coming to you. And this has led to the recycling of old ideas being new again, this idea of inhibiting secondary hemostasis to prevent ACS events. Is all being re-explored, and it's a very active area of investigation. DOACs do appear to reduce cardiac events if you get the right dose and the right drug. Rivaroxaban, low dose. Some of the other ones appear to bust. Real-world data that we've been involved in shows that DOACs may reduce cardiac events in patients who need anticoagulation versus warfarin, and it does appear that in patients with lower GFRs, this effect may be even greater. RCTs are underway, hopefully coming to Canada soon. And there are apps at the patient level to help them use this data, interpret this data, and help physicians work with their patient partners to apply this data so they can make individualized decisions regarding anticoagulation therapy. So with that, we'll conclude. This is my risk-benefit ratio right here. It's mostly benefit, but they do keep me up at night sometimes. And with that, I'd like to acknowledge a lot of people who helped in this work, and this is my icon collection. And with that, I'd like to welcome any questions, comments, anything. Thank you.
Great, thank you for that. Any questions that come to people's minds? Go ahead.
Thank you so much for the talk. Can you tell me in your database, when you went through the ICES, where the GFR is less than 30, do you know how many of those were dialysis patients? Because I don't know how Ontario works, but here in our dialysis unit, we don't have a lot of patients on DOACs.
So we excluded all the dialysis right up front. We excluded all dialysis, all transplant, right out. Oh. So they were strictly CKD patients. Now to comment on your second point, that's fair, not to put patients on dialysis on DOACs. And that's, it's reasonable. It's a conservative approach. We don't have the data. There's a pile of trials coming, Renal AF and a bunch of other ones. Some of them are failing to recruit. And a lot of these trials are looking at warfarin versus DOACs for specifically AFib in dialysis. The results hopefully will come in 5 years or so. It's not answering the more interesting question, I think, which is whether we should be anticoagulating them at all on dialysis. And there's 2 trials for that are on their way as well. One from France, and then one is starting up in Ontario with Ziv at St. Mike's as the PI. My experience, anecdotal, and I call all my anecdotal advice pseudoscience because it is. My last name's Sood. Is that it's really effective. I put people on apixaban on the hemo unit, and they have very few problems. And that's versus warfarin fluctuations, warfarin's INR fluctuations, which are crazy. There have been good studies on dialysis patients show 60% of the time, or even higher, they are not in the therapeutic range of 2 to 3. They're all over the place. Then they get an infection, and you give them Cipro, and their INR comes back at 11 the next time. And we see this all the time, and we accept it, and we're used to it. And you give them apixaban, and you don't see any of that. You don't measure INR anymore. It just works. Now, of course, there's bleeding risks, and I don't say it flippantly, just I'll give it. You have to make sure you have protocols in place within your hospital, usually set up by hematology, on how to handle DOAC-related bleeding. You don't want to give it to anybody who's on transplant list, who might get called in the middle of the night, and then they have to wait 3 days for their organ. So there are people you have to make careful considerations of who you give it in. But in general, I've been using it more. The Americans are using it a lot now. But the data hasn't emerged, but anecdotally you talk to them, they're just putting everybody on it. But it's something to explore. Is anybody here prescribed rivaroxaban or any DOAC? Any of the physicians? Apixaban for who? For CKD. But it's rare. We are out of that world, right? It's the general internists and cardiologists who are in that world, and we get the trickle down of seeing, hey, look at this patient's on rivaroxaban. But I think this trial will specifically challenge us, if the results are positive, to be more engaged with anticoagulation prescription.
BCH, Diamond, do you guys have any questions?
Yeah.
Thanks, Manish, for that great presentation. I have a question for you about your approach to the risk-benefit trade-off when you're asking patients to quantify that. One of the challenges is that you're asking patients to assess their perceptions of events that they haven't perceived or haven't experienced. And within the TRACK trial, are you going to be evaluating their perceived risk-benefit trade-off, specifically within groups of patients that either experience outcome events or experience bleeding events?
It's a terrific question. Just to back up a little bit, on the app, you're right. We do provide education, so we try to describe the events in lay language. It's not that detailed, but we try to describe that, a bleeding event usually entails, and then go through a short admission to hospital, a possible invasive procedure, not eating for a few days. So we do describe those events. But you're right, it's not imperfect knowledge. There is nothing specifically in the TRACK trial to look at that at this point. There's a lot of outcomes going to be done. There's a lot of things to be measured, cost effectiveness, et cetera. But there isn't anything about risk trade-offs, patient perceptions. And it's a terrific idea because we could apply for that as a sub-study easily and integrate this app, for example, into it and have them do this app as a part of it. One other last piece on that, it's a great question, thank you, is many of you may have heard there's a lot of science behind traditional decision aids. But if anybody's actually done them, Ottawa has a huge decision aid research wing. And it's very good science, it's amazing science. But if you actually do it, it's a ton of work because it usually involves systematic reviews, determining each node, probabilities. It's a tremendous amount of work involved. What we're trying to do with this app isn't essentially replace that excellent work, but to do it quickly and easily. And we avoid a lot of that background work, and instead we just use ISIS data to give us a probability, and we don't even adjust for anything, and we just put it in to inform the decision making and let people get some idea to make their decision. So it is a bit of a quick and dirty, but the idea is you can use it and apply it much quicker than current decision aid methodology and aids that are fully developed.
I was going to make a comment on that. I think it'd be great to have a date on it because then you can update the decision aids when more data is available, because I think that's the one thing is that they become outdated and people are still using old information. But I do think it's a great idea, and Ottawa has done a lot of good work on decision aids, period, not just in the nephrology space.
Yeah.
And it would fit nicely into CanSolve and other things. I'd like to go back to your warfarin example. It's interesting, and it'd be good for us to have a discussion. For a drug that has so much harm, that is so difficult to monitor, in whom we all know from all the data that our patients are rarely in range, I wonder why we keep prescribing. You know what I mean? Yeah, but it's not like a policy that we don't, and it's not like everybody doesn't, right? I think it'd be interesting for the nephrology community to be a little bit more consistent with that approach, because actually it's just bad medicine.
There's a lot of argument that there's no way this drug would have ever approved in the modern era. It's a dirty drug. And if you look international patterns of prescription, there are countries that completely say, forget it. We're not giving warfarin to anybody on dialysis, and Germany is the classic. They have like nil people on this drug. They don't anticoagulate them. They just say it's dangerous and we're not doing it, and it causes calcification, and they just ignore it. Canada's one of the high-end users. U.S. is one of the higher users, but other countries like Germany just stop the slate.
So here's an easy natural experiment. Why don't we just ask all the dialysis patients to stop their warfarin and just follow and see at 0.0 what happens? I mean, you wonder what the morbidity, never mind the phone calls and the extra blood tests and all the things that go on with warfarin. But because the valves, yes, the valves.
The valves are different, and the antiphospholipid antibody is different, and the VTP stuff is different.
To see how many of those there are.
Yeah.
This is how it lists. Only one. Yeah. And even then, we're not doing a great job. Yeah, that's true. Yeah.
I think we did a look in ours, and we have like maybe 750, 800 dialysis patients, and I think we found a number, I'm just going offhand, it's like 40 to 60, something like that. So it's there. It's interesting that we accept this drug. One last piece, just for fun. We have 5 minutes. There are tons of drug interactions with warfarin. We all see this every day, right? Like you give them an antibiotic and then boom, INRS 11. And that's one of the major problems with that drug is the number of drug interactions. Now DOACs, there's no literature on drug interactions. There's nil. And so that could be a possible worry, right? Because there's a lot of polypharmacy in our patient cohort. So if anybody's into that stuff, it's a CYP3A4 metabolized drugs, so drugs that theoretically inhibit CYP3A4 should increase the levels of at least rivaroxaban and apixaban significantly and lead to bleeding events. We have done a bunch of studies that are about to come out looking at the risk of getting a strong CYP inhibitor, CYP3A4 inhibitor, plus apixaban or rivaroxaban versus a weak or non-CYP3A4 inhibitor and the anticoagulant and the subsequent risk of hemorrhage. So we looked at the major cardiac drugs. We looked at, the biggest one is clarithromycin. That's one of the strongest ones. And we have not found a significant risk of increased bleeding. So just that piece of the concern of drug interaction seems to be much, much smaller than anything we ever see with the traditional warfarin. It's just one more piece in the armamentarium for that.
Great. Thanks for really stimulating talk this Friday morning. Much appreciated.
Thank you.